Good afternoon, everyone. Welcome to today's Menzies Research Seminar. As we begin, I'd like to acknowledge the traditional owners of the lands that we're meeting on today, the Malaria people, and pay my respects to elders past, present and emerging. And I also extend that respect to any Aboriginal and Torres Strait Islander people joining us here today or online. It's my absolute pleasure to be joined by Associate Professor Kamala Thriemer today as she presents on universal radical cure and how this helps support the elimination of malaria. As per usual, we'll have a little bit of time for questions at the end, but without any further ado, Kamala, I'll hand it over to you.
Thank you. Thanks, Penny. Hi, everyone. I'd also like to begin by acknowledging the traditional owners of the land we meet today and pay my respect to elders past and present. Lovely to see so many of you here. Lots of familiar faces. Lovely that there are a few non-malaria people in the room as well. So I wanted to talk about universal radical cure. And for those who attended some of the other malaria-related talks over the last years, you might have heard a lot about radical cure in general, and universal radical cure is potentially kind of the next step to move on as an additional tool. So there you go. You explained it to me how it works, but there you go. So radical cure is used for Vivax malaria. Vivax malaria has this very interesting feature of being able to form what we call dormant liver stages or hypnozoites that stay in the liver and can relapse weeks or months after the initial infection. And at least in some areas, up to 80% of the acute presentations are caused by those relapses. And this is really relevant in the context of malaria elimination, because a lot of our conventional malaria control and elimination tools are very much focused on preventing infections. So if you think of bed nets or insecticide spraying, as well as treatment of the acute disease phase, and they really don't kind of address those dormant liver forms. And so when we talk about radical cure, we talk of that combined treatment of both the blood forms of the parasite as well as the liver forms of the parasite. And you see them here kind of on the left-hand side, they're what we call tricentennial treatment, so the blood stages of the parasite, and then on the right-hand side, those liver stages. And there are really only 2 drugs available, which makes it potentially easy. And I'm going to talk mainly about primaquine today, but there is a new treatment available now, tafenoquine, that has a couple of advantages, particularly in terms of improved adherence, because it's just a single dose treatment compared to a fairly long dose that we're using for primaquine. So when we talk about universal radical cure, we really talk about extending the indication of when we use radical cure. So currently, when you present with falciparum malaria, you just get treatment for your blood stage infection, whereas if you present with a Vivax episode or a mixed infection, you would get your blood stage treatment plus your hypnozoidicidal treatment, so a combined radical cure. And when we talk about universal radical cure, we talk about expanding this radical curative treatment to patients who are presenting with falciparum malaria in areas that are co-endemic for both species. So why would we do this? Why do we think this might be a good idea? So this is data from a systematic review done a few years back now, pooling data from trials that looked at falciparum patients. And normally we kind of do those trials in falciparum patients looking at how well their treatment works for their falciparum malaria. And then if patients have a Vivax episode in between, they might just get censored in their kind of intention to treat analysis. But so we use this data to actually look at Vivax as an outcome. What you can see here, that there is an increased risk of having a Vivax episode after a falciparum episode, and this risk is higher than you would expect from the normal kind of background relapse rate. And interesting, this is increased in areas that have short relapse periodicity. And as you can see on the forest plot here, particular increased in when we use drugs, kind of tricentennial or blood stage drugs that have a shorter half-life. So you can see at the bottom here with AL, which is alpha-methyllumefantrine, that has a shorter half-life than DP, for example. And you see that risk is increased there. So, The bottom line, if you present in co-endemic areas with falciparum malaria, get treated, your risk of having a Vivax malaria is actually larger than that of having a falciparum episode straight after it. And this again here shows that increased risk, particularly after AL. And on the right-hand side, sorry, you can see that this risk is also increased based on related to the initial parasite clearance, really suggesting sorry, that relapses might be triggered by those febrile illnesses of the acute falciparum malaria. We have some early evidence that universal radical cure might be working, and this is data from a large trial that Rick and Rini conducted in Timica, cluster randomized trial, looking at supervised versus unsupervised radical cure among patients who present with PV and PF. And if we just look at those PV patients, at these PF patients that presented, and looking at their risk of Vivax afterwards, you see that in the unsupervised treatment arm, this is larger. And the assumption here is that in the unsupervised group, patients actually only received either parts, but only took parts of the treatment and therefore weren't protected. However, this risk of Vivax after falciparum might be different in different locations and depending on endemicity. This is data from the Thai-Myanmar border looking over a longer period of time, showing that this risk actually decreases as malaria goes down overall. So suggesting that it might be more beneficial in some areas than in others. So based on this, we kind of thought of a kind of a prospective, I guess, randomized controlled trial to look at whether radical cure, universal radical cure, would have a benefit in co-endemic areas. And we started the study pre-COVID in 2019, then had quite a bit of a break in between, as you can imagine, but we're able to finish early last year, I think. And so this was a study done across 3 different countries, Bangladesh, Indonesia, and Ethiopia, where we randomized patients that presented with falciparum malaria into a control arm that received blood stage treatment and a single dose primaquine as a transmission blocking treatment, which is kind of current standard care in most countries. And then the intervention arm that you see here, where we used a high dose primaquine treatment over 7 days as radical cure treatment here. So the high-dose primaquine treatment is something that isn't used or recommended yet in many places, but we've done a lot of work on that. And I think earlier in the year, Rob Commons presented pooled analysis data showing that high-dose primaquine treatment is more beneficial than the currently lower dose that is currently used in most area. But there is an increased concern around safety the more we increase the doses. And I'll talk about the safety data that we get from this study that is not only relevant for universal radical cure, but for radical cure in general a bit more. But it means also one of the main issues around safety is the risk of hemolysis, particularly in patients who have a certain enzyme deficiency called G6PD. And so we screened patients to ensure that they were all G6PD normal when they received this higher dose primaquine treatment. And then we followed patients up looking at Vivax recurrences as an outcome. And as I mentioned, we recruited in those 3 countries. Those are the endpoints. I'm not going to go through all of them, just highlighting that we looked both at efficacy endpoints as well as safety endpoints. And our primary endpoint, the incidence risk of Vivax at 63 days, kind of highlighted there in bold. And when we look at the safety outcomes, you see there are a few safety endpoints around gastrointestinal tolerability, because we know this is a concern, particularly if we increase dosing. And then the hemolytic outcomes, particular because we are worried about hemolysis, particular in patients who are G6PD deficient, but also in general a potential risk of HB drops that we might be seeing with higher primaquine doses. So quite a few patients were screened, as you can see, across those 3 sites. Then randomized 500 patients. At the analysis stage, we had to exclude a few that were wrongly enrolled, unfortunately. And we were able to include 246 and 249 in the intention to treat analysis. I'm not going to present the per protocol analysis, but you see the numbers here, and in a nutshell, the results between the per protocol and intention to treat analysis are pretty similar. And this is the main result, really. So you can see on the y-axis the cumulative risk of any Vivex episode during the study. On the x-axis, the time between enrollment and to the last follow-up. In red, the standard care, so the control arm, and then in blue, the intervention arm with the high-dose primaquine treatment. And you see that there's about a 5-fold decrease in the risk of Vivex malaria among patients, among falciparum patients who were treated with radical cure. So quite encouraging, certainly a significant result here. This is the same in red, highlighted the same result that I just showed you in the graph. And in the lines below, you see kind of the earlier endpoints on the same endpoint, but at an earlier time point on day 42 and day 28, very similar results here. And we don't see the same result when we look at falciparum as an outcome, which you wouldn't expect to see, because we know that radical kind of primaquine treatment wouldn't have an effect on that. If we zoom in terms of the different countries or the different blood stage treatments that we see, we get a bit of a more granular picture. So on the top part, we have the results divided by patients who received alpha-methyllumefantrine as a blood stage treatment, which was used in Bangladesh and the Ethiopian site as part of the routine care. And then below that, the patients who received DHA piperequine at the Indonesian site. And you see very clearly that those results are driven by the patients who received AL rather than those that received DHA piperequine. And again, that's in line with what we would expect based on the results from the pooled analysis that we did earlier. AL having a much shorter half-life compared to DHA piperequine. And then at the bottom part here, you see it divided up by sites. Of course, a question of sample size as well, with a very large, the biggest part of the biggest number of patients recruited in Ethiopia compared to rather modest numbers in the other sites. But I guess suggesting that, when we kind of potentially advocate for universal radical cure, we would expect it to be more beneficial in some areas compared to others. And certainly Ethiopia would be a good place to think about that. So safety, I mentioned before, the main issue when we think about safety of higher doses of primaquine is twofold, really, around GI tolerability and then the hemolytic events. I'll start with the GI tolerability, and you can see there were 2 SAEs, severe adverse events, in the study, both in the high-dose primaquine arm, both around GI symptoms. They both resolved fairly quickly, and the treating clinicians thought they were unlikely related to treatment. I think for the first one, there is certainly kind of a bit of a temporal connection here, and could be perhaps judged differently as well. Very limited vomiting, and we know that some of the issues that we see around GI tolerability are likely to be mitigated by food or providing food with the treatment. And unfortunately, most previous trials have either not provided food or at least not recorded it very well. And so we were never really able to kind of detangle whether patients who received food with their treatment were actually tolerating it better. In this study, we consistently provided food with all the treatment doses that patients received. And that's really encouraging, I think, because as you can see, there are hardly any differences in terms of some of the GI symptoms that we would normally see among the 2 groups, really suggesting that that's a fairly simple way and cheap way to kind of mitigate some of those symptoms on GI tolerability that we are seeing, where a lot of people, I think, have concerns around how much that GI symptomatic episodes potentially affect adherence to treatment. And that is in line with other data that just came out of PNG by Brian and Moore, looking at even higher doses of primaquine among children, and again, providing treatment with food kind of really seemed to have negated any of those GI symptoms. So coming to hemolysis or hematological outcomes here, So what we are worried is potential falls in hemoglobin. And you can see here that there were a couple of patients who dropped. So no one dropped to below 5 gram per deciliter that you can see here at the bottom line for day 2 and day 7. But there were a couple of cases who dropped to down to 7 or just above 7. But similarly, we know that malaria generates hemolysis. So not only the treatment can potentially cause hemolysis, but the malaria episode itself. And it certainly looks from this data that if we really make sure that we exclude any patients who are G6PD deficient and therefore at much higher risk of hemolysis, that this dose is pretty safe. And that's quite relevant, not just for universal radical cure, but for improving radical cure in general. And if we look kind of over the entire period of follow-up, you can see that between the control group in orange and the intervention group in blue, we really don't see any differences here. So in conclusion, we can say that this universal radical cure treatment with higher dose of primaquine was fairly well tolerated and reduced the risk of Vivax in patients who present initially with falciparum malaria quite significantly. And it potentially really provides just an extension and an additional tool when we think of malaria elimination, just because when we think of Vivax malaria, there's other conventional tools are so so limiting really, and this hidden Vivax parasite reservoir that we are having in the liver could potentially be targeted at that point of care when patients present with falciparum malaria. And then, as I mentioned, quite reassuring additional safety data for high dose primaquine in general, so not only for universal radical cure, but for radical cure overall. So just want to acknowledge particularly our collaborators in Bangladesh, Ethiopia, and Indonesia. They've done a massive work. It was a very challenging study with a huge break in between due to COVID and restarting kind of at halftime of the COVID pandemic, and moving all our kind of trial conduct to a very different working model from not being able to travel anymore and having to do all the training online. And so a big shout out to Sophie Weston, who was the trial manager when we started and really has moved us into that kind of virtual space. And then the rest of the team, Helen and Grant and Angela, to bring the study over the line, and the team at UniMelb, of course, for all the stats analysis at the end. So thank you.